My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
On today's episode, we have the privilege of speaking with Dr. Gerard Baltazar, who I will be working with in the future at my residency. Dr. Baltazar is a trauma and intensive care surgeon at NYU Langone Health. Dr. Baltazar obtained his undergraduate degree in biology and fine arts from Georgetown University and his DO degree from Touro University in 2007. He completed his general surgical residency at Wyckoff Heights Medical Center in Brooklyn, New York, and finished a fellowship in trauma and surgical critical care at Rutgers University Hospital in Newark, New Jersey. He has received several regional, state, and national awards for scientific research, writing, and community service. His research interests include traumatic brain injury, international medicine, and osteopathic manipulative treatment for surgical patients. He has volunteered for surgical missions on 3 continents and was the recipient of the 2015 Oriens Award from the Eastern Association for the Surgery of Trauma. Before joining NYU Long Island School of Medicine, Dr. Baltazar was the director of surgical critical care at a safety net hospital in the Bronx. We hope you enjoyed this episode.
Gerard, thank you so much for being with us tonight.
Thank you. This is really a pleasure. I've been looking forward to this.
We're over 40 episodes at this point, and I think the exciting thing for the team is that we're having awesome DOs like yourself listen to us and reach out and talk to us about being on the show. Our whole team is so excited that you reached out to us. We're really happy to have you on.
I'm honored, and it's going to be a pleasure, I'm sure.
So, Gerard, you're a general surgeon, is that correct?
Trauma and critical care is my subspecialty.
You're at NYU Long Island, is that right?
That's correct.
So for our listeners, tell us a little bit about what a trauma surgeon is and does, and then a little bit about NYU Long Island.
A trauma surgeon specializes in surgical critical care as the fellowship, and if you have a particular interest in doing more trauma, you can do a critical care fellowship where you are involved in a lot of injured patient care. And so my particular interest is in injured patients and the intensive care, but the overall picture of what they're calling an acute care surgeon is today involves managing the emergency general surgery that comes through the ER, the trauma surgery that comes through the trauma bay, and the intensive care unit. So on a rotating basis.
So Gerard, just, for me, I haven't done any of this stuff in a long time. So we talk about trauma. Are we mostly talking about like motor vehicle accidents or gunshot wounds or mechanical injuries? Like what type of things would you take care of?
It very much depends on the trauma center that you're participating in. There are trauma centers that see a lot more violent trauma and others that see mostly blunt trauma. And by violent trauma, I'm pointing towards the penetrating type of trauma. And in my career, I've done both. At the moment, Long Island NYU Long Island tends to be more of a blunt trauma center, although we do get our share of penetrating trauma and violent trauma.
Okay, that sounds very stressful.
It is. There are 3 specialties that tend to have the highest rates of burnout. There's emergency medicine, there's general surgery, and then there is intensive care. And at my specialty, we choose to do all 3. So indeed, it is one of the most stressful specialties you can be part of.
Yeah, I can absolutely imagine why. I mean, there's not a lot to think about why you would get burnt out doing all that. That's crazy. We are really excited that one of our producers, Tian-Yu Shea, actually just matched for medicine at NYU Long Island, and he could not be more thrilled. I think they were really lucky to have him, and he's really lucky to be there. Can you just tell us a little bit about the hospital?
The hospital is actually a really interesting place. It has this history of being a community hospital with a lot of high quality care delivered to the patients. With NYU coming in and bringing its abilities and resources, it's the quality of the care, I think, has gone up, and it's become much more world-class in the type of care it can provide and the diversity of specialties that they can provide as well. In terms of the trauma center has grown tremendously in the 2 years that I've been there, because the NYU team has brought in myself and others who have kind of a broader experience than I think that when it was NYU Winthrop, they had as a trauma center. So we're really expanding our reach as trauma surgeons, acute care surgeons, and the intensive care as well has gotten more advanced.
Gerard, part of the reason, and again, we're gonna come full circle and talk more about you and your journey and how you got here. But part of the reason why we're so excited to have you on the podcast is your contributions and thoughts on osteopathic manipulative therapy, specifically as an osteopathic surgeon. Now, it's interesting, obviously we've had some people on the podcast before that specialize in osteopathic manipulative therapy, and a lot of primary care docs incorporate it into their practice. It's always interesting for us to speak to different specialties where you would think that maybe there wouldn't be a role for osteopathic therapy, and then we find out that there is. And even when I was looking you up on the internet and reading up your bio, I found an course that you were giving at the American College of Osteopathic Surgeons called Evidence-Based OMT for Surgical Patients. So I was hoping that we could just start really at the back end. And again, I know this is not the main part of what you do, but talk to us about osteopathic manipulative therapy and how you incorporate that and how a surgeon would incorporate that into their practice.
Well, I don't want to go too far back into my history just yet, but it really does start from the very beginning of my my education and my career. I have always felt akin to multiple different types of approaches to everything. And when I first discovered osteopathic medicine, it clicked. I remember picking up that really thick book of medical schools, which, back in the day, that's what we had to find out where the medical schools were. Now those don't exist. But in the back of that book, there's a thinner section that had these osteopathic schools. And once I finally got there, after flipping through all these schools and saying, not really, something dawned on me. This made sense. It was a combination of the traditional Western way of doing medicine and this odd, fantastic, holistic thing. And I chose to go to osteopathic medical school, and because I wanted to make sure that I kept that kind of combination of abilities and thoughts and principles alive within me. And so when I went forward to surgery, it was not like I'm doing osteopathic manipulation and I'm doing surgery on the other. They're two different things. I aimed to make sure I could do them both at the same time and find the best way to do that. So as you kind of put it, maybe this isn't the thing I do the most, but it's something I do on the regular. So if there's ever a situation that I find myself in where I think that osteopathic manipulation would be useful for my surgical patients, my trauma patients in the intensive care unit, I do it. I think of it as an extra tool and an extra way of approaching a clinical care, and I'm constantly applying it as often as I can and find it appropriate.
Gerard, can you give us some examples of places in your practice where you feel that osteopathic manipulation really makes a difference or adds to conventional therapy?
Pain control would be one of the most easy ones to understand. I think the literature also supports that doing manipulation is evidence-based for pain management. I find that, especially in the trauma world, that there's a lot of somatic dysfunctions that contribute to patients' pain, especially after some force has been applied to their body or they've undergone an operation and all the trauma that comes along with having an operation. One great story that kind of illustrates how this tool becomes useful is I was making rounds on my trauma acute care surgery service, and I walked into a patient's room, and there was an elderly lady who had broken her hip, and she was writhing in pain. Her family was at the bedside distressed. Apparently this had been going on for the last 10 minutes, and they were concerned that she was in so much pain. I asked the nurse, can you bring some pain meds? And she said, oh, it's got to come up from the pharmacy. So I went over to her bedside. It was clear that she was having a spasm in the area of her fracture. I got on my knees, picked up her leg, did some balanced ligamentous tension, a little bit of myofascial release, and her spasm stopped. And she started to drift off to sleep, saying, "Thank you, thank you, thank you so much." And then, after she fell asleep, the nurse comes in the room and says, "Oh, the pain meds are here." So in that instant, there was an opportunity to do something with OMT that without that ability, I would have just had to sit there and wait for medicine to arrive.
That's an awesome story. I mean, I think that's just amazing. And it's something that you had in your toolbox that a physician that didn't have that training obviously would not have been able to give to their patient.
I find in trauma in particular, there are a couple of realms where osteopathic manipulation might play a role that is very distinct. One of them is in brain injury, and the other is in rib somatic dysfunction. At NYU Langone, Long Island, I am the chest wall trauma guy. I'm the one that has done most rib fixations and chest wall reconstructions for people who have had bad injuries to their ribs or motor vehicle crashes and the like. And what I find is treating patients osteopathically after a rib injury or chest wall injury or after a video-assisted thoracoscopic surgery or thoracotomy, that the patients actually do better. They have better inspiratory abilities. They can take in more vital capacity. They have less pain, and they're more mobile as well. And actually, this is borne out in at least one randomized controlled trial out of Italy, where they looked at patients who had sternotomies performed and randomized them after the sternotomy to either osteopathic manipulation or not. And the osteopathic manipulation group had both significantly decreased pain, and not both, but three things: significantly decreased pain, significantly improved inspiratory volume, and significantly reduced hospital length of stay. So I'm excited to pursue research in that vein for chest wall injuries and to see if we can recreate some of those same findings with doing manipulation in the trauma setting. And then when it comes to brain injury, concussion, and the like, we're finding that there's more opportunities to treat patients where they're specifically for what the palpatory findings for their cranium, their cervical spine, their upper extremities that are contributing to the post-concussive syndrome or the post-TBI syndrome. There are very few specific treatments that we can give for just someone who has post-concussion syndrome, for example, and they're quite scattershot. And the general rule of thumb is just wait and see what happens. That's what you tell a patient when they've got the photophobia and it's been a week since 2 weeks, 3 weeks, a month since their concussion. Oh, they still get headaches. Well, just wait and see. It should get better. Or maybe some painkillers, or maybe even antidepressants you can throw at that situation. But it's a challenging thing. And when I've treated patients who have these symptoms, they always have somatic dysfunction, of course, and you treat them and they do better. I've had the opportunity to publish just some case studies on these patients, and hopefully we're going to build up into doing a larger study. We do have a paper that's yet unpublished, but we have the data already collected on a retrospective study looking at moderate and severe traumatic brain injury patients who survived to discharge. And among that patient, the cohort that had received osteopathic manipulation during their acute care of their traumatic brain injuries, those patients had a significantly less likely chance of ending up at a subacute rehab and a nearly significant trend towards going home. In other words, that the patients who had received osteopathic manipulation and survived moderate to severe traumatic brain injury were more likely to meet the metrics that made them safe to go home. So there is an opportunity here to examine something that I think that examine a realm of medicine, the cranium, and the central nervous system, that the osteopaths have a very unique way of looking at and helping with.
Now, Gerard, you're obviously a well-trained surgeon, and you're at a high-ranking, quote-unquote, allopathic institution. When you bring these things up to your MD colleagues and the administration of NYU? Do you find that they're supportive and interested in these things, or are they looking at you like, what the heck are you talking about?
I've given grand rounds on this subject. I've voiced interest in research, and the support has been fantastic. There's been from the chairman down, they're interested. They want to see more work product. And recently, my team has given me a clinic to do osteopathic manipulative treatment for post-injury and perioperative patients, which we're now going into our 4th month, and it's always full.
Do you have MD residents that want to learn these techniques? Are they interested as well?
Some. They're surgical residents, so they're quite busy. I think that the more experience that I have and more publications that come out, the more interest that the residents will have once they start seeing what happens and start to understand it more. Because I don't fault them for not being interested off the bat. Even the DBO residents, they haven't had experience with someone doing this kind of work within the world of surgery. It's not very often that they see that. So I understand that they have other interests, and this is an interest that I'm sure is somewhere in the back of some people's minds, but there's so much else that they have to do first. And I think once more it becomes more commonplace at this institution, and maybe even more reputable at this institution, they'll take more notice. I do know that in my group, among my partners, because I've treated some of them and they've seen me treat patients and they have no idea why the patients got better, but they did. They have nicknamed me Magic Fingers, Magic Fingers Baltazar.
It's cool. I like it.
Yeah.
Gerard, let me ask you a little personal question that I wasn't able to answer. So the Do or Do Not podcast crew was invited in August to be on another podcast called the Short Code Podcast. And we ended up having a lot of discussion about osteopathic manipulation. And one of the questions that they asked us was about osteopathic manipulation and postoperative ileus. Do you have any insight into that?
Yeah, I find that there is some measurable improvement in patients in terms of their overall function. And scientifically speaking, there is some evidence to support bowel function, including a paper I published on it back in residency with my team from my general surgery residency, that where we found a statistically improved return of bowel function and improved length of stay of bowel resection patients.
Yeah, I didn't have that at my fingertips when they asked, but it sounds like it's something that makes physiologic sense.
It does. I'm hedging just a bit because when you've got an overwhelming abdominal catastrophe, not much is going to help you. And even if you want to try to modulate the autonomic nervous system, sometimes the disease is just too intense. And being someone who works in kind of the extremes of illness, sometimes it's not, you don't get the effect you want. And it's frustrating, but then again, that's just disease in general, right? If disease is too powerful, no medicine, no manipulation is going to help. But if you focus and look at a specific type of subset of patients, you can, as we showed in our study, you can see a difference.
Gerard, I'm going to shift gears and we're going to go back to our sort of normal program and ask you to tell me, in your normal day, obviously you do a lot of different things in your position. Tell me what your normal day looks like. We're going to focus on you. Tell me what time you wake up in the morning and what you do in a typical day, and run us through till what time you get home and go to bed.
Oh, wow. That's a lot. Well, let's see. I get up around 5 usually, and then I try and do my thing at home, maybe do a little bit of housework, and before I end up getting ready to go to the hospital, drive into the hospital. If we have a meeting, usually the first meeting is 6:50, attend that meeting, and then depending on the week, there'll be a way we run rounds. So let's say I'll be covering the trauma service. Then the trauma service starts at 8. we'll have morning report, do some education, and then start making floor rounds. After the floor rounds are done, then we'll just anticipate any traumas coming in, and whenever there's something comes through the trauma bay, we'll deal with it. If there are consults for other types of cases, emergency general surgery, we'll attend to those, and while also managing the floors. There are assorted administrative duties, research duties that are intermixed during that day in between various cases. If I have to go to the operating room for any emergencies, I'll do that as well. And that can be, that can throw off the whole schedule and whole plan for the day, but it must be done. And then if there is if things have cleared out for the day, then by around 5 p.m., there's a handoff to the team member who's on overnight, or I'll be on for a full 24, depending on the day. And then the night runs pretty much the same, except there's fewer people in-house. And at the same time, we're managing the floors, and anything that comes in as an emergency, we're also managing the ICU.
Yeah, crazy day.
It is. And it's strange to think sometimes when I have a moment of peace and I look back and what did I do today? Or I'm with friends or family that don't do this kind of thing. Even my wife, who's also a physician, but when I talk about my day, sometimes she just looks at me and says, I don't know how you do it. And you get used to anything.
So let's take us back a little bit. Tell us a little bit about, your parents and your family growing up, and when you became interested in medicine and decided that you wanted to be a doctor.
Well, I grew up in a family of medical people, a lot of nurses and some doctors. My mom was an OBGYN. She's retired now. That's actually how I got my name. Gerard is the patron saint of pregnant women. The idea of becoming a doctor was always brought up in our household. But I'm the only one actually among my siblings who pursued medicine. And I was determined to kind of pursue it in my own way, in a way that was focused kind of on saving people, if you will. I always wanted to kind of find people at their worst and try and be there to support them. And so that idea was born actually out of some family trouble that we had. I am a survivor of domestic violence, what I guess they're calling intimate partner violence now. And it has informed my wish to pursue a career where I can be there for people on their worst day. And that became how I planned to do medicine, and that led me into trauma surgery.
That's deep. We're gonna. I have more questions. That is, I wish I had an answer. That is some answer. My answer would not be that deep, but that's amazing. I'm gonna, again, just a little bit of a lighter question. Tell us where you went to undergraduate, and were there any specific experiences in your undergraduate school that led you into medicine, and specifically into osteopathic school? I know you told us a little bit about that Barron's book. I had that too, and a lot of our listeners probably don't know about that, but I get that part too.
Well, I went to Georgetown University in Washington, D.C., and what I remember about that experience that led me into medicine and trauma surgery was and osteopathic medicine actually, in particular, was my attraction to doing research in something that wasn't kind of a standard biomedical type of research. I had received a scholarship from the Howard Hughes Institute to do research, and we were really supposed to be doing biomedical research, but I loved the idea of doing environmental conservation type research. So I convinced them to let me do that, and because I was doing genetic research in that field, they allowed me to apply my scholarship there. And I think that the idea of working in a field where you're doing hard science, bench research, genetics, but you're also examining the world as a whole, was just felt beautifully poetic to me. And that sense of poetry was built in me over the years of working in that field. And when I found osteopathic medicine in the back of that Barron's book, I got the same kind of feeling.
So you applied to osteopathic school, and how did you choose the school? What school did you go to, and how did you choose that school? and tell us a little bit about your experiences in medical school.
I ended up at Touro University in California, and a bit by providence, actually. I did like the school. I liked the fact that they had a very strong osteopathic manipulative medicine department. I also liked the fact that it was in California, on the other side of the world from where I grew up, and I was younger. I wanted to have some adventures and discover another part of the world. But I also liked that I ended up there by providence. I was waitlisted initially, and at one point I was on an airplane flying, I forget where now, but I had an anatomy book, and I was, just for fun, I was opening up an anatomy book and reading it. This guy, a couple of rows ahead of me, he was walking to the bathroom, he's walking back, he sees me with this anatomy book, and so he taps me on the shoulder and starts talking to me. Turns out he's one of the reputable professors at Touro, California. And
that's crazy. Yeah, what a story! Holy cow!
And we have conversation, and we have a conversation. We end up talking about Touro, California. He says who he is. I say who I am, and that I'm waitlisted. And he says, "Don't worry." And then The next thing I know, I get a letter of acceptance.
Yeah, if you believe in like a higher power, I think that's about as close as you get to evidence, right?
Yeah, and so I made the most out of it out there. I had a really great time. I really invested a lot in pursuing the osteopathic stuff, not just the manipulation, but the whole spirit of the profession. The things that we talk about being at the heart of what we're trying to do, holistic medicine, if you will, but really caring about the patient as a whole, caring about everything from top to bottom, and not being overly focused on a specialty or subspecialty. And I feel very, very lucky that I was in an institution that really held on to those. Part of it was because of the Jewish tradition at Touro. That Jewish tradition really intermingled well with the osteopathic principles and practice. So it was there was a lot of more of that feeling of poetry and spirit.
Gerard, you mentioned that you did research when you were an undergrad. Were there things that you did while you were in medical school, like research or extracurricular activities? And did you decide to take the USMLE before you applied to residency?
I didn't do research in medical school. Personally, I was going through a lot of change and exciting change, just kind of discovering myself outside of the world I was most familiar. I did pursue some interesting things, from which I earned a couple awards for medical school for community service and student life. And one of the things I did was I founded the Touro Clowns group, where I got some of my students to dress up and act as clowns and go to the children's hospitals and such. And I also worked on the newsletter and turned it into a full-on little magazine with some excellent graphics and more dynamic writing. And those were nice pursuits, and they were more in line at that time of my life with what I think I needed, which was exploring different parts of my above life, clowning and writing journalism. So it made a nice balance to the hard work that you have to put in to study and succeed in medical school.
And did you take the USMLE, or did you just take the COMLEX?
I'm a bit of a at the time, I was a bit pretentious about saying that why do DOs have to do two different tests? And so I opted only to take the COMLEX.
Gerard, for the record, I did the same thing, and I felt the same way as you. So, we're kindred spirits on that.
Yeah, I knew I liked you.
Yeah, exactly. We're friends. We started off as friends. So, how did you decide? So, surgery is, obviously you have to be passionate about surgery to choose surgery because it's a big commitment. When did you decide that you wanted to do surgery? And can you tell us a little bit about what your application process and how you picked your residency?
I decided to do surgery. I think it was September of my fourth year of medical school. I had gone into medical school thinking I'm going to do emergency medicine. I had been an EMT. It seemed to fit in that whole paradigm of wanting to help people at their worst moment in life. But what I found was I wanted to do more definitive work, and I wanted to work with my hands. I love being a DO because I work with my hands, and I found that the more rotations I did in emergency medicine, the more I realized I wasn't working with my hands as much. And so I started thinking about surgery probably the end of my third year of medical school, and then I finally decided to put in the application very late into my fourth year. And I luckily had a decent enough application that I got several interviews, and I decided that I wanted to go to an osteopathic program, partly because, again, I'm a little bit wanting to support the osteopathic world. There's a bit of a brain drain, as I'm sure many people know about, at least before the merger, where the graduates with higher scores tended to matriculate to ACGME programs. And I didn't want to be that. I had high scores, but I had a philosophy that I'm not going to matriculate to an ACGME. I'm going to stay within the DO world because I want to up the level of the DO program that I'm in. So, and on top of that, I wanted to be in the center of the universe, New York City. So I found an osteopathic program in New York City who granted me an interview, liked my application, and it was in an underserved community in Brooklyn, which fit with my the poetry of what I thought my life was about, and and it helped to satisfy that passion of helping those on their worst days.
We recently interviewed a surgical resident, and she kind of made light of it. But life as a surgical resident is pretty tough, right? Like, what kind of recommendations would you make? Like, if someone was, some of our listeners are thinking about surgery, what was your residency like, and what kind of advice would you give for people thinking about surgery?
My residency was very, very challenging. It was a type of residency where you are constantly working, where you're constantly fatigued, where you're being pushed to limit, which is most surgical residencies. But in particular, because we didn't have the accoutrements you might find in an institution that has a lot more resources, you had to do a lot more things on your own. But I was able to get a lot of extra skill set from that. And the nurses would call me to put in IVs, for instance, or I knew where all the equipment was and how to set it up. If you choose to go to a residency like that, you have to be very prepared to work hard and to be able, after the work is done, to find a way to enjoy the time you have outside, which is going to be not a lot. And if you don't have an ability to create that work-life balance when you start, you got to figure it out right away after you start, because you can crash and burn very easily. And I've had colleagues that did. With the 15 of us that started that were there when I started as an intern, I think at least 2 dropped out. So, or pursued other things for a time and then came back, one of them. But it's a very difficult life, but it makes you a better person if you apply yourself correctly to it.
Gerard, how did you, or when did you decide that you wanted to do fellowship? How did you pick your fellowship, and where did you ultimately do your fellowship?
Well, when I decided to move from emergency medicine to surgery, I knew I had to pursue trauma surgery because of the intense emergency aspect to it. And I enjoyed the intensive care too, because again, you're standing there trying to keep somebody from the brink of death a lot of the time. So I knew I was going to pursue trauma surgery. Some of my colleagues tried to talk me out of it. They said, "Oh, you have the scores to go to this specialty or that more reputable specialty in surgery." And I said, "This is my passion. I wanted to do it." And I ended up initially actually at a 2-year acute care surgery fellowship, which was one of these newer fellowships that was being created at Hartford Hospital in Connecticut. It wasn't a good match. I think that at that time in my life, I wasn't ready for something that more strictly academic, with very little penetrating trauma, and really you're doing a lot of, it was more administrative and that sort of thing. And I really wanted to be more in the thick of it. So I ended up leaving that fellowship and pursuing a trauma-heavy fellowship at Rutgers at University Hospital in Newark, which was fantastic. I mean, you're there in the middle of essentially a war zone, and you have great resources of people, at least, and resources in terms of technology to do your best to help them. And even then from that to do outreach into the community to try to make a dent in the cycle of violence.
For the listeners that don't know Newark, if you're looking for trauma, I would think Newark is a very good place to set up shop if you want to find trauma patients. That's right, huh?
Yes, absolutely.
Gerard, we're very excited that Tianyu is going to NYU for his internal medicine residency, but you are attending at NYU, which is, considered sort of an elite allopathic institution. Can you tell us a little bit about applying for a position there and how you felt you were received as a DO? Obviously, you're working there and you're doing a great job and you're doing all this research and it sounds awesome. But can you tell me a little bit about when you got the job at NYU?
Yeah, well, I initially chose, once again, after I finished fellowship, to go to a traditionally osteopathic program. So I was in the Bronx working at a trauma center in the Bronx in a high intensity violent trauma part of the city. But after a while, I knew I needed to pursue something more if I wanted to make a deeper impact on my community and also to give myself some space to pursue other things in my personal life and also in my academic career. And at that time, I had friends who were moving in to take leadership roles, to take a leadership role at NYU, and she recruited me. We've been friends for quite some time. We actually met at Hartford, and she was always had gotten along, and she knew the quality of my work through organizations like the Eastern Association for the Surgery of Trauma and others, and we made a good fit as a team at NYU. And so I ended up actually spending about a year thinking about the position before deciding to matriculate there. The matriculation at the beginning of it was challenging. My history of working in the inner city for so long was a bit of a clash with the suburban culture. And I think at first blush, being literally the only DO in the division, and I think only one of maybe a couple DOs in the entire department, there was hesitance. It's just not I don't know why. I can't speak to anybody's thoughts on the matter, but there was hesitance. But after a while, you show your stuff, you prove that you've got good skills, that you have a range of talents, and that you have unique talents, and that earned me respect, and it's been since then quite a nice ride. I think that's really a lesson that is true about a lot of osteopathic pursuits in life. If you want to really stand out as an osteopath, you kind of have to push past discrimination. You have to push past the stigma against you. There's a book called Doctor's Orders. I don't know if you've had a chance to read it. Tanya Jenkins wrote it, and she talks about this. This is a phenomenon well understood. The DOs are going to face discrimination, not necessarily because they have individual deficits, but because the system as a whole sometimes does not support DO students and DO residents in the same way that systems for allopathic students and allopathic residents have historically. That may be changing as we have come under a unified ACGME. But because of that history, you have to work it a little bit harder. And at first, I wanted to actually maybe take a step back. I thought, why don't I just go back to my osteopathic hospital where they know me, But that's not what you do. You face a challenge, you step up your game, you make yourself better. You look at yourself, you make yourself better, and you keep on fighting for what you believe in.
Yeah, that statement is 100% why we wanted you on this podcast. And I think that's amazing.
It's worked out well so far.
Gerard, I'm going to switch gears. I'm just going to ask you a few personal questions, if you're okay answering them. We're always interested in whether people took loans and whether that affected their choice of residency.
However challenging my family has been, they have always been supportive financially. And I was lucky enough that I did not have to take out loans for medical school. And I think that has helped me in my career to pursue more broad ideas, if you will, more maybe even you could say more idealistic ideas, because I had the opportunity without having to worry about about funding. But now I'm actually in the process of trying to figure out how to do funding for grants and getting research funding, which is its own special challenge.
Gerard, are you married, and can you tell us what your spouse does and if they've always been supportive of your career?
My wife is a PM&R physician. We actually met when I was a surgical resident and she was a medical student. Clearly, yeah, she's been supportive of my career. She's been supportive of me being a DO and my pursuit of combining the ideas of advanced surgery and osteopathic manipulation. She's great. She's PM&R, which physical medicine and rehabilitation. So she is interested in the musculoskeletal system. She doesn't have a background doing manual treatments, but she does see the value in it. And I think she's very proud of me of continuing to use those skills, even though I'm in a field that doesn't traditionally use them.
Gerard, first of all, thank you so much for your time. I mean, you have been absolutely inspiring and great, and I love talking to you. Our grand finale question is, this is a tough one. Everybody has a problem with this one, but I think it's great. What was the best piece of advice, and it could be more than one piece of advice, that you were given from someone else throughout your education? And this could be, from growing up, medical school, residency, that you think really gave you value and you would like to pass on to other students?
Dr. Akela Chandrasekhar, one of my mentors and who really shepherded me through residency, and especially during the tougher times of residency. Great guy, really great heart. He was the resident academic, or he was the academic guy in the residency, attending wise. And I admired him, and I wanted to be a scientific writer like him. I wanted to pursue that part of medicine. And so I asked him one day, how do I become a writer? And he said to me, you just write. And then you're a writer. You may not be a good writer right away, but you're a writer. And then you just work at it and you get better. And that's a lesson that I've seen heard reflected in various things. Like I worked with landmark education at one point, and that idea of if you want to be something, you be it, and then you get the results of it. And I think that's something that is hard for many younger people in medicine to appreciate. They think that there's some kind of pathway that you have to follow, and there's certain milestones you hit, and then now you have achieved something. Now you are this. The idea of that lesson is that if this is something that's true to your true self, it's true to your heart, and it's something you're passionate about, do it. And then you are it. And then all the other things that you think you want from it will flow from that. So I kept asking him, how do I be a writer? How do I be a writer? And he says, you just write.
Good advice. Love it. Gerard, thank you so much for your time. I really appreciate you being with us tonight.
Thank you. This was a lot of fun, and I look forward to building a friendship.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.